Good afternoon and welcome back. We appreciate those of you who are online as well as in the room joining us for this afternoon session. We're continuing our clinical care subcommittee presentations. We have a couple today, and then we're going to have, after 3 o'clock, presentations from our risk reduction. So leading us off today, this afternoon, we have Amy Bain, who is the Senior Director for Health Systems with the Alzheimer's Association. Since launching the Health Systems Initiative in 2019, she has partnered with clinicians and leaders to spearhead transformative initiatives that advance dementia detection, care management, not just in primary care, but also in hospitals, health systems, and health plans. And she's done this in many states, including Michigan, Ohio, and West Virginia. I'd give you Amy.
Okay. All right. Hello. Good afternoon to those in the room and those that are joining us virtually. I realize I'm after lunch, so the pressure is on, right, to bring us back up from that the great lunch that we had. Thank you so much to Dr. Mims for the invite to talk a little bit about the health system assessment readiness, the value of it, and kind of our role at the Alzheimer's Association as we tackle this. But first, I want to walk through a little bit of a story. I want you to imagine a large health system with state-of-the-art facilities and well-trained staff. But there's one critical gap that they're facing: the readiness to handle the growing wave of dementia cases that they're seeing. A typical day for them brings in an older patient into the busy ER. Her symptoms are confusion, agitation, memory loss, and these aren't new, but there's no clear plan on assessing her cognitive health. The staff, of course, they're great. They're focusing on immediate issues, but we know that dementia care is complex. It requires specialized approach, and with this health system, they don't have it built into their protocols. Across their system, their clinicians are working hard, but many have not received the training on how to spot early signs of dementia, let alone engaging the patient and the family in care planning. There's a lack of standardized screening tools, which means some patients with dementia are missed entirely, while others might be getting a referral to specialty care or community-based organizations only after their condition has significantly worsened. At their leadership level, they recognize that there is a need for better care, but competing priorities such as financial pressures, staff shortages that they're seeing, and the constant influx of patient make it very difficult to build a comprehensive dementia care pathway. They're also dealing with a fragmented data system, which means that it's really difficult to track outcomes. So even the leaders who want to make a difference to improve care, they don't have a full picture of what's working and what's not. And let's also pretend that we're not in Phoenix and there's not the amazing Hospice of the Valley to refer the patient and caregiver to. This is the picture of many health systems across the country. It also is the picture of the challenge of health system readiness. It is not that people do not care about this disease or find that it's not important. It's the struggles of building the infrastructure, training their team, and having the resources align to deliver that consistent, effective dementia care across the continuum. So today I'm going to talk a little bit about health system assessment readiness. What exactly does it mean? Why is it important? I will touch on the Alzheimer's Association's approach to support. We'll do a dive into data that can help address current state. And then we'll talk about other factors to consider as a system might be going through this improvement process. So as we start talking about assessment and readiness, our friends over at the health system readiness.com, they said that health system readiness is the ability of a health system to promptly and sustainably adapt its policies, infrastructures, and processes to support the integration of innovation and innovative approaches to care. Why does this matter? Well, the purpose of readiness is to ensure that your system has the ability to successfully adopt changes that it's planning on making. It's critical to ensure the implementation of new programs, improving patient outcomes, and enhancing operational efficiencies truly stick, right? And so making sure that you're evaluating all the different pieces of readiness before you adopt a system change is critical. So the goals with the Alzheimer's Association Health System Initiative, we launched this initiative back in 2019, and it really was a response to our 2019 facts and figures. Our special report that year was dementia in primary care. And I'll share a little bit about what we were able to find after surveying 1,000 physicians across the country. But that really did spark the launch of this initiative. And it really is to understand the needs of our clinicians so we can help meet the complex care challenges that they're facing. And also supporting clinicians with strategies and solutions that can ensure quality of care for people living with dementia. If I were to boil it down, I would say we are working to improve the early and accurate diagnosis of dementia and work with our health systems and our clinical partners to drive the improved quality of care delivered after the time of diagnosis. So in the facts and figures special report that year, as I mentioned, we surveyed 1,000 clinicians across the country. And here are some of the barriers and challenges and feedback that we received from them as it relates to screening, providing quality care after diagnosis. Here were some of the barriers. Knowledge. This probably is not a surprise to anyone in the room or for those of you joining us online. Knowledge. Primary care providers don't know what to do before and after diagnosis. Incentive. Disease is not a priority and providers are not adequately reimbursed to address it. Capacity. There's no time in their current model for an in-depth interaction to diagnose early. I hear quite frequently, I cannot fit one more conversation, one more screening into the very short visit that I have with my patients. And then the mindset. It's difficult to diagnose and it doesn't change treatment. I will be coming back to this slide a little bit later on because we've had a lot of momentum specifically on this right-hand side around incentives and around treatment that truly are changing the mindsets over this last year. We are fortunate to have health system directors located across the country. We are subject matter experts, and we work with health systems to identify areas of opportunity by performing gap analysis and identifying where there are potential gaps, using data, of course, and then utilizing the quality improvement best practices to drive improvement efforts. And then ultimately, we want to drive systematic changes within our health system as well. So the ideal patient journey from awareness of cognitive issues to treatment, and really this is just a visual for you to understand that this is a continuum of care. And really, this is just one snapshot, one example. I mean, we could add on here risk reduction. We could add on to the end of life care as well. This is just a snapshot to say quality improvement and making changes can happen anywhere across this continuum. From primary care, identifying memory concerns and having that conversation, to referring to specialty care, biomarker testing, treatment, and then also strong care navigation. Okay, so before you get started with an improvement effort, it's important to also realize that there are key factors that are at play. And if you're aware of those, you can help hopefully mitigate some of the barriers and challenges that you might face during your improvement efforts. One is clinical readiness. So, do you have the staff capacity? Do you have the people power that you need to help support improved care? Are you able to adjust your workflow and utilize different team members to help provide support? Does your team feel confident and capable with dementia screening, with dementia diagnosis, with dementia care? Do you have a willing team? And if you are getting no's, being able to ask some questions and continue to peel back the layers to identify where these no's might be coming from. Operational readiness. So with operational readiness, we're looking at things like infrastructure. And one of the things that came to mind, especially over this last year, as we were supporting and watching many of our health system partners introduce treatment into their health system, there was a heavy lift with infrastructure. Screening protocols had to be in place, referrals to specialty care, PET imaging, MRIs. All of this required a significant amount of infrastructure to be able to deliver treatment. Additionally, looking at things like resources. Do you need to invest in new positions to be able to handle navigation or care management? And then, of course, leadership buy-in, critical as you are trying to advance this work. Your administration might be struggling in prioritizing dementia care based on other competing priorities. And so making sure that you're having conversations and you're understanding what are the current priorities within the systems to ensure you're getting that commitment. Finally, technology readiness, looking at things like data management. And we will talk about this a little bit later as we start looking at some data points to pull, but do you have access to be able to pull that information? Do you need to pull someone from informatics that can help you pull reports so you can start gathering that baseline? EHR support. So you might be working on an intervention that is enhancing your EHR. What type of IT support do you also need to be part of this improvement effort? And then interoperability. So do you have systems that are truly communicating with each other? Is your EHR in the hospital communicating with the EHR in primary care and so forth? Addressing framework and tools. So depending on where you plan on starting your improvement effort, there might be tools and frameworks already in place to help support. And we don't necessarily want to reinvent the wheel, but making sure that you're aware of different tools and frameworks to help in the effort. So the first thing, I have different quality improvement assessments listed here: SWOT analysis, ORC assessment, the PEST analysis. I would recommend, if you have the opportunity to pull in someone from your system that's in quality improvement, that you're pulling them into the fold. One, they can help frame the quality improvement work. And two, many times these individuals know the priorities within the health system. They know the metrics that are important. They know what their leadership wants, and they can also help guide some of this improvement effort. And then supporting guidance and framework from partner organizations, the World Health Organization, the CDC, IHI, other evidence-based care models, and then, of course, the Alzheimer's Association. So here at the Alzheimer's Association, I'll talk a little bit about our work and how we partner with health systems to be that strategic advisor, roll up our sleeves, and provide that technical support. I always say I don't necessarily need to lead a quality improvement project within a health system, but certainly we'd love to be at the table to help walk through some of these key components. So making sure that you're identifying key champions. And as we know, health systems are large, they're complex, and there are a lot of moving parts. And we are out working in health systems, building different partnerships. So sometimes it's within primary care and neurology and specific inpatient departments. So we can help connect the dots within health systems. We can help establish current state baseline using data points that I'll be sharing in a couple of slides. And then we can help create what the ideal state and outcomes you might want to achieve and help inform the plan as well. So identifying current state. So this is the part where we're going to start looking at data points that your system can start analyzing as you're tackling improvement efforts. And again, this is a snapshot. We have worked with health systems over the last, going on 6 years now, and started to collect, as we're having these conversations, the important data points that they're looking at, and also being able to come up with some new data points that they might want to consider. And so you'll see, and I won't go through it, line by line, but we have data elements, we have the criteria to review, and we have the considerations that you might want to make by looking at these specific points. So first things first, making sure that you're reviewing the patients that you're planning on serving and really kind of putting up a population health lens on this, reviewing your demographics. So I know we often will start projects for those 65 and older, screening projects, improvement projects. The Medicare annual wellness visit starts at 65, so that's kind of an easy number as well. But we have some partners who say, you know what, we're actually starting that brain health conversation a lot earlier, and we're actually going to start at age 55 and having those conversations. So depending on your project, it might change the age that you're looking at, but it's important to know who your population is, and then starting to dice that a little bit more. What is the gender and ethnicity? What is the marital status and living situation? So we know that 2/3 of people living with dementia are women. Does your data also reflect that? We also know that this disease impacts the brown and Black communities at a larger pace. Is your data reflecting that? And then with marital status and living situation, one, we know that social isolation was associated with about a 50% increased risk of dementia. But we also know that it is critical during this journey that the patient has a strong caregiver team behind them, whether living with them or family or friends around them. So making sure that you're identifying that as well. And then we were able to pull some ICD-10 codes that you could look at. Again, how many of your patients 65 and older are living with dementia? And again, things to take into consideration here, points to take into consideration. Half of people living with dementia don't understand that they have the diagnosis, or maybe they don't have the diagnosis. So you will see here in the ICD-10 diagnostic codes, there is a code for unspecified dementia. And actually, I was working with a health system who had pulled some of this information, and that was an alarming data point for them. They had a lot of their patients being coded as unspecified dementia. And for the champion I was working with, she said, no, we don't want to see this. We actually want to see that number going down and an accurate diagnosis being made. So that was part of her improvement project, looking at that. Other items to take into consideration: of those impacted by dementia, how many are manifesting behavioral health symptoms, and pulling ICD-10 codes to look at that. So we know that approximately 30 to 90% of patients with dementia suffer from behavioral symptoms that could potentially land them in the emergency room, make it more challenging for their caregiver to provide the right care. And so knowing that could also be a potential improvement area. How are you building the confidence of the caregiver and the caregiving team? Another point: how many patients are prescribed dementia-related medications? And of these, how many have an actual diagnosis in their record? So many times we find that that patients are being prescribed medications that are typical for dementia, but they don't have that dementia diagnosis in their chart. And so this is another way for you to, again, look at your data. How many dementia patients are receiving psychiatric medications? And what are those common psychiatric medications that providers are prescribing. We know that non-pharmacological options are the first line of treatment, and that could potentially raise a red flag there, looking at that data point. Now, this one looks a little different, a different format, but still very similar, except that we're taking a look at acute and or behavioral health. And again, looking at very similar, the first one, diagnosing ADRD. So looking at your total number of 65 and older, what of your percent of your population actually has a diagnosis. But then we're starting to take a deeper dive here. We're looking at things like behavioral health care transition, and looking for ways using your data to potentially improve patient experience, the caregiver experience, decreasing unnecessary admissions to the emergency department, care transitions, inpatient length of stay. We know that that is an important metric that many health system leaders are looking at on a regular basis, along with 30-day readmission rate. Again, all of this is going to help you identify opportunities to right size and improve length of stay, 30-day readmission, hospital-acquired conditions. So pulling your rate of hospital-acquired conditions and looking at it from an ADRD versus non-ADRD perspective to get kind of a full picture of what's happening within your system. And then again, emergency department length of stays as well. I had an opportunity to talk to a VP of quality improvement at one of our systems. And I was talking kind of in general about our health system initiative, and he was being very polite, listening. But then I started talking about, is it possible if you were starting to diagnose your patients earlier and getting them on a strong care management plan that you could start reducing 30-day readmissions and reducing average length of stay? And you could actually see him kind of sit up in his chair. And he said to me, now you have my full attention, because these are metrics I am being measured on a regular basis. These are reports that my leadership, they want to see on a regular basis. So for him and for many out there, these specific data points are critical. Other prevalence rate questions that you can start asking yourself as well. I think it was mentioned before, we know that many of those impacted with dementia are also are dealing with another comorbidity. And so it's also thinking about, as we know, diabetes and hypertension and a lot of other chronic diseases are typically prioritized within a health system. But how does the treatment of diabetes or hypertension change with a diagnosis of dementia? And looking at things like that. Another, fall risk. And again, this is another one that many of our health systems are looking at. And so looking at overall total falls, how many of those are 65 and older with a diagnosis of dementia versus a non-diagnosis of dementia? So doing all of that, looking at your data, this gives you the opportunity to really gather what that current state looks like. And of course, we're going to use all of that to inform what we want our ideal or future state to look like. So first, we're going to start defining, after we pull all that information, we're going to start defining our vision. So what do we want success to look like? How will this align with our metrics and goals? And what are the best possible outcomes in patient care along the dementia care continuum? And I'm going to incorporate a little story through this. So in this case, the health system we're working with, they say, our ideal state is where every patient at risk for dementia receives timely screening, followed by a comprehensive care plan that improves long-term outcomes. This will involve seamless workflows, engaged clinical teams, and a robust tracking system. Sounds easy, right? So again, remember what that ideal patient journey could potentially look like, and knowing that at any point within this journey, there's room for improvement, right? And so once you have your vision statement, you know where you want to go. It's time to start comparing that to your current state and conducting that gap analysis. So what gaps actually exist between that current state and ideal state? Also remembering what is going well. Maybe that's what is going well with dementia care. Maybe that's what is going well with other chronic diseases that we've tackled, what is going well within a specific department. Maybe you have a strong case management team that can provide support to patients and caregivers after the time of diagnosis. But what are you doing to get them to that great care management team? So acknowledging what's going well is really critical. But then also looking at what are the potential barriers that you will face during this process. So in the story that I'm talking about, we set our vision statement. Now, since we've done the gap analysis, we know that currently only 40% of patients over the age of 65 are receiving routine cognitive screenings. Our gap analysis highlights several barriers, including lack of clinician time, inadequate screening tools, inconsistent documentation practices. So once you have done the gap analysis, you can really start focusing on your plan. And so what does it mean to build the roadmap? Prioritize interventions. So as I mentioned in the little story, there were several things that they wanted to tackle, but the reality is where are you going to start? And what is most important in those interventions? Making sure that you're creating specific action steps, that you're assigning responsibility, that you're setting measurable goals, and that you're measuring the progress and working on continuous improvement along the way. Interventions, as we look at those could include anything from clinical education to EHR enhancements, workflow changes, and the list could go on and on and on. But in the case that we're talking about, they decided to bridge the gap between the current 40% screening rate and our ideal state of 90%. We will first integrate the cognitive screening tool into the EHR. We will then train all of our clinical staff on its use, and we'll monitor the progress weekly. Our clinical champions will lead peer-to-peer training sessions and ensure that workflows are optimized. Here's an example. We had an opportunity to be part of an improvement project in the state of California, working with the Dementia Care Aware Group. And part of this was to kind of test out our health system initiative throughout the entire improvement process. But they were very kind in putting this logic model together during the evaluation piece. But I wanted to share this as again, this is really great on having a quality improvement person as part of your team because they love logic models. But here, identifying what is the situation? What are we trying to improve? And in this case, and I know it's super small, dementia screening tools are underutilized in community clinics throughout California. Dementia diagnosis is delayed along with treatment and support. So knowing what inputs we need, we need staff time, we need evidence-based models, we need QI expertise. In this case, they wanted to form an advisory group, and they wanted to make sure that they had data tracking efforts in place. They identified their outputs right away, their participation, the activities, the direct products, and so who they wanted to reach, what they wanted to do once they were able to reach them, and then what needed to be created to help support those individuals. They also thought about what short-term, intermediate, and long-term outcomes do we want to see based on all of this work that we're doing. In addition to that, they also gathered assumptions being made, as well as external factors that could be at play to either help move their work forward and or be a barrier to their work. So they looked at external factors as well. So this is just an example of how this work kind of all comes together, and in this case, in a logic model format. As you're doing this work, it's important to think about some of the common challenges and barriers that you might be encountering along the way, or you would anticipate in encountering along the way. Remember, I told you we would come back to this slide. So again, this is back in 2019, and some of the common challenges that we were able to find that our primary care clinicians had across the board. So again, knowledge and capacity, we talked about that. What I want to highlight here is the incentives and the mindset. And this, over the last year, we've seen a lot of movement on. Incentives, we've talked about it. We had the introduction of the CMMI GUIDE pilot model that now offers reimbursement to that high-touch, high-quality dementia care being offered. We've also talked about other billing codes that could be utilized as well. So, is it still adequate reimbursement? I don't know if that's the case, but we do have reimbursement out there to help support this work. Mindset. So here it was difficult to diagnose, and it doesn't really change the way we would provide treatment. Well, we have FDA approved treatments for Alzheimer's, and although not everyone qualifies for those, it is an option now. And I say all of that, there's a lot of momentum happening right now in the world of Alzheimer's and dementia care. It's always exciting to hear all of our scientific updates, our research updates, and just know that we are going to continue to move at a fast pace as it relates to biomarker testing, as it relates to more treatments out there. So this is an exciting time for this disease, and an exciting time for a health system to say, you know what, it's time to get on board with this. So other tips, tools, and what else you need to know. Number one, I say this often, we know healthcare is complex. We also know this disease is complex. So if this work was easy, it would already be done. So let's acknowledge that right off the bat. Also, as a health system's looking to tackle improvement efforts, it's always important to highlight, again, the impact of cognitive impairment on other comorbidities. It's also really important to think about quality versus quantity. And as I mentioned, my ultimate goal is to create systematic changes. But the reality is many of our health systems start small, and they start with a small practice. They start with a hospital. They start with a department. And they're testing out, is this working? They're looking at those outcomes that we had talked about. And then the goal then, of course, is to scale throughout their entire system. No is usually a not now or not in that way. And I would challenge anyone who's getting a no from their leadership or other clinicians to continue to uncover why they're getting that no. Is it the value proposition? Do they not understand the value of this work? Are there other competing priorities and so forth? Making sure that you're aligning with current priorities and connecting those with dementia. Screening is just the first step. And here I will quickly share a story. I worked with a health system, a small health system in Northeast Ohio, and worked with their chief medical officer over primary care. And when I was talking to him, he said, I know what I do as the chief medical officer. I know what I do in my clinic, but I don't know what we do across the board. So let's get our clinicians some education. They went through our Project Echo series for primary care. And then soon after we met again, and he said, listen, I think that education's great, but at the end of the day, I'm a quality guy. So I need to know that the time we're investing in this is actually doing something. So I want you to work with the nurse practitioner, pull some data, and let's find a project to improve on. And so we did that. They pulled their 65 and older and found that less than 5% had a documented cognitive screening in their medical record. And so after we pulled a small focus group, we identified, it's probably happening more frequently. It's not being documented appropriately. They use different screening tools across the board. And for this system, they thought we need to have a consistent screening tool because they wanted to make some EHR enhancements. They also adjusted their workflow to identify the medical assistants would be the one to do a mini cog and then tee the clinician up for a deeper conversation if it was necessary. We met 3 months later with that small focus group and said, how are things going? And they said, it's great. We're screening a lot of people now, but what are we supposed to be doing next? what happens if we do identify a potential cognitive decline? What do you want us to do next? So we were so focused on this screening project that we quickly had to think beyond. Remember that dementia care continuum. We had to think, okay, well, and so we went to the chief medical officer and he said, you know what, I want them to have autonomy over their patient, but I want a menu of items built into our EHR so they know that they can order lab work, they can order imaging, maybe they're going to do a more in-depth cognitive assessment. And also we want to put them in touch with the geriatrician and neurologist for consult purposes as well. So again, I go back to screening is just the first step in this work. There's a lot of other opportunity for improvement throughout the continuum. Remembering this is a marathon, not a sprint. And because I guess I really mean it, I put it in here twice. If this work was easy, it would be done. And then also, last but not least, making sure that you're sharing and celebrating successes along the way, because we know this work is hard, but also we want to be able to share promising practices with other health systems. We want to make sure, as the Alzheimer's Association, and I'm sure other groups out there, want to provide a platform for our health systems that are doing great work to be able to talk about and talk through how their changes were in place and the success that they've been able to see. More tools and resources that we have over the last year, we have built out specific readiness tools as it relates to dementia care navigation, as well as a dementia treatment readiness checklist. And then in the middle here, you will see we've created kind of this process chart algorithm to help our primary care clinicians as they develop out a dementia clinical pathway. I always say that one of the best tools in our toolbox are our health system directors. And again, we have health system directors that are located across the country, rolling up their sleeves every single day to build stronger partnerships with our health systems, identify where there are potential gaps, talk to them about some of the tools and resources, and also listening for those promising practices that are starting to bubble up as well. So we do have them located all throughout the country. And if you're sitting here in the room or you're sitting at your computer watching virtually, if you would like to be in contact with any of your health system directors locally, you can contact me, Amy Boehm. I'm the Senior Director for Health Systems. My email address is there and would be happy to connect you with your local health system director. Thank you.
I don't know. Okay, perfect. Thank you so much, Amy, for a great presentation. I'm just gonna have like 2 questions and maybe just open up to everybody. This is definitely a wonderful initiative. So thank you so much for informing us about this. It wasn't clear to me like how many of the partners that you have, they are coming from like rural areas. So I wanted to see if you have like these connections already in place with clinicians and also healthcare systems that are in the rural areas. Or if not, like what are the plans, if you have any plans to expand in that direction? Because I imagine that the gaps and the challenges, the resources, everything.
Sure.
Different.
And yes, absolutely. So we have strategies to work with rural health as well as federally qualified health centers. And you're right, the challenges are great. Many times these are also areas that do not have neurologists and geriatricians as well. So it's really what can we do to help equip primary care to not only screen, but to diagnose and provide quality care. We have education available to help build the confidence and competence of our rural health providers. And we're also doing this great work that we're doing with large systems with small rural clinics as well.
Perfect. I'm really glad to hear that. And the second part is, and I noticed that you mentioned like individuals older than 65, and the program provides a lot of resources, but any plans to extend it to early onset dementia, like including that as part of the readiness in the future?
You know, we put that age on there. And again, many times that specific age is kind of triggered by that Medicare annual wellness visit. But as we know, especially now that we have treatment, we're identifying people earlier. And so, you know, when I'm working with a health system, it's really talking to them about where do you want to put the stake in the ground as far as starting maybe it's not screening, but starting the conversation around brain health. And especially as we start thinking about things like risk reduction, and I know we'll be talking about that later on today, but the risk reduction conversation certainly is happening much earlier. So it's working with our health system partners to identify where do they want to start with this and where do they want to put the stake in the ground.
Adrian?
Thank you. This was very good. And from a quality improvement hat, I just heard all of those different tools there. But I also heard it as a way of engaging others. So if they know the percentage of their people over 65 who is being admitted to the hospital and readmitted, and then they begin to look at the comorbidities of those who are being readmitted, those with dementia, but they also have diabetes, and they're being admitted and readmitted because they can't follow the care plan. It allows them to make more specific interventions. Now you can bring in cardiology. Now you can bring in other specific groups because you have the data to show them. So thank you for that.
Thank you.
Rhonda?
Oh, yes, thank you so much. And we're working with Liz McCarthy from our region and are finding it extremely helpful. What I wanted to ask you, and I love the inclusion of data to help us tell the story as it is, and also help a work group determine where do we want to go and how are we going to know when we're making progress. I wanted to ask you, have you started with health systems to use data associated with the preventive service codes, for example, where putting into practice more counseling on addressing hypertension or high cholesterol, and what's, if you are doing that, what's been the response of some of your health system partners in doing that? Thanks.
And thank you. And I'm also a big fan of Liz McCarthy. So thanks for that little shout out for her. No, actually, I have not, but I'm curious, have you? And what is the response that you're getting if you have?
Well, we're talking about it, but we still are working on the baseline of the codes you shared. But I would love to talk with you and your, more team members at the Alzheimer's Association about it. I think that I will just say, we are looking at our hypertension codes with our accountable care organization. And at a recent meeting and pulling up our last 10 years of data, it's been pretty status quo, about 68%, 70%. And the target 5-7 years ago had been reaching 80%. And so it's just, it was very revealing. And health system leaders were saying, how can we do better? Just in hypertension management. And as we know from the data around dementia risk reduction, we need to improve in this area. And we're not even talking about, high cholesterol or some of the other key factors. So thanks for asking. Hopefully in a year or two when we talk, we'll have more to share on that.
Perfect. Thank you. And this is an example of promising practice, right? This is why we want to follow and partner with our health systems. So that way we can hear the great work that's coming out of these systems and be able to share experiences with other systems. Thank you.
Bruce?
I'm curious, with your exposure to multiple health systems, varying sizes across the country, if you're starting to, in a systematic way, collect any data or understanding about what the leverage points for them are, what's the why, and is there anything you can share about that from your experience? Are you looking at that in a systematic way?
And actually, it's interesting you bring that up. We within the last year or so, we brought on to our MedSci team an individual that's helping with health system research. So I think that this is also, it's not so much that we're doing all this great work. I mean, that is a lot, but how are we tracking and ensuring that it's moving the needle and finding those, like you said, levers that are truly being pulled to gain the attention and moving the work forward. Joanne?
I think the one piece that I might add within there is that in absence of large scale incentives to provide quality care, this is mostly individual anecdotal information for the most part. Like when we started back in 2019 on this work, it really required a champion within the health system who believed in this and who was willing to take it forward. I think as a cause, right, as a movement, create an infrastructure for better quality care, and we're incentivizing our entire medical system from physician through advanced practitioner to provide that, we will begin to see a more systemic desire to do this. But as of right now, I think we're just kind of in that middle ground where it used to be very personalized and now it's getting deeper. Sherry might have some knowledge about this too, though.
Yeah, and first of all, thank you for the presentation. I'm sorry I was late to return. I think this is your point, Joanne, about, what would we consider incentives? We have to also acknowledge that there are different incentives depending on who the audience is. So who are you incentivizing to do what, right? Which is, I think, really important. We have a list of codes. We've got like 36 something codes that are included in the guide model that sometimes people don't even use because it's not worth in the calculus of it all. So I would argue that any information that you can glean that informs us of what the variables are in the new calculus would be really important. It is not a matter of fee for service. And this is exactly also one of the important reasons why CMS proposed and finalized the age-friendly attestation measure for inpatient quality reporting. It's a start. It is but importantly, it's not going to look the same for every single facility, but it's got all the good stuff in it as far as domains. So what can we do with that? The door is open. It is an attestation measure that health systems could actually use in ways that actually make meaningful change and improve outcomes for.
And when we have talked about doing even just a webinar talking about the different billing codes and making sure everyone's aware and how to use those, talking about quality measures that are out there as well. It certainly still takes a clinical champion to say this work is important.
Indeed it does. And I would also up the ante. It's not just quality measures, but it's also quality improvement. Like you find these data points and you know what the gaps are. That's the first important step to improvement. And it's just, human nature. Everybody thinks we're at the top of the curve when it comes to how we practice and how we provide care until you see your own data.
That's right.
So anyway, thank you so much for the work.
Yes, thank you. This was like an exciting to see all of it come together and to know that you all are out there talking to the health systems. And I want to pick up a few threads of things that people have mentioned, and then also something we were talking about last night, which is that luckily, I'll put that in quotes, our population has challenges with chronic conditions, right? So we were wondering if you have people who can't manage their diabetes, are they the ones that should be screened for dementia? Is it people who are being readmitted all the time that should be screened for dementia? Is it, and this has come up in different settings, the high costers for Medicare. They're usually not people with dementia at the end of life, but a high proportion of like the top 10% or 1% are people with dementia. And so the more that you guys are finding that, if I could encourage you to publish it, it would be amazing, because maybe we don't screen everyone over 65 for dementia, but if you have these other things, they should be screened for dementia. And so not just making the case to the health systems, but more broadly that we're seeing these folks, they're not able to manage their chronic conditions. And so be on the lookout for dementia, because this is probably your population. And then it will, to your point, Bruce, make the business case, because that's what we ding the health system on, that these are the folks that they should be intervening on and identifying.
Thank you very much, Amy and Yakil. It's that undiagnosed person is the challenge. We're not doing enough of those diagnoses. So now we're going to switch to another group here. We've talked a lot about dementia care specialists, and we are very, very fortunate to have in the room with us today one of the originators of one of these programs, Kristen Felton. And she thought of this before it was a name. And she thought about this. She thought about this way before it became a funded program. In 1996, as a direct caregiver in assisted living. In 2001, she was in an assisted living in another facility. But she began working with the Wisconsin Department of Health and Services and focusing on that group of people with aging and disability, and realized we need to figure this out, how to create the ideal program for them. And we are so blessed that she's been able to come in the room and be with us today and talk about the origins of Dementia Care Specialist Program. After she presents, we have a dissemination of that within Georgia, and I'll wait and introduce Stacy then. Okay, Kristen? Mike, the microphone.
Okay. Now everyone can hear me. So I just want to thank everyone for inviting me to speak on this program. It's my baby. I love talking about it. So it's going to be very hard for me to stick to 15 minutes. All right. So just an overall discussion of what the purpose of the program is. And of course, it starts with focusing on the people who are living with dementia and their families, their caregivers, and helping to enhance their quality of life while they're on this journey. It's also to reduce dementia-related crisis events. There's a lot that can be done to help prevent individuals from ending up in a crisis that has a type of dementia. And those things rarely work out well for that person with dementia when they get involved with the crisis system. So trying to prevent crises is another focus. Reducing the burden on the larger systems. So there can be repeated hospitalizations, repeated crisis calls, first responders having to go out, repeated visits that may not be necessary to a physician because they haven't been recognized as having a type of dementia, but have diabetes and are no longer able to manage. So there are a lot of things that can be prevented that are unnecessary for people who are living with dementia and their families if they are supported and given the right tools as they go through the journey. And then the last is, it's really a lifespan program. It's not just focused on people living with dementia and their caregivers, but it looks to the whole community and it looks to everyone across the lifespan. We heard earlier today a desire to have this kind of education in schools. And we actually have a curriculum that we've created with the Department of Public Instruction around brain health. It involves information about the brain, about dementia, and about how to provide care for somebody in your family that may have dementia, because kids absolutely are caregivers too. I forgot to change my slide, sorry. All right, so the funding actually was identified in 2012, but it took us about 6 months to be able to start actual program activities. We had 5 in our pilot program and expanded to 16 in 2014. And something that's important that I want to make sure I say here is that the dementia care specialists in Wisconsin are not state employees. The state does not hire and supervise the dementia care specialists. They provide funding to the counties who then hire and supervise their dementia care specialist. And it's an important feature because having that person who is connecting with these families and sharing resources, having them be local and be a part of their community to really understand what the challenges they may face are compared to another county, what resources they can make use of. So it's important for the person who's a dementia care specialist to really be in the community itself as a part of it. So in 2015, we recognized that we did not have a dementia care specialist in our tribal nations. So we started off with 3 in a pilot with the tribes to see what we could learn, which turned out to be quite a bit. In 2017, as you can see, this is when funding began to really ramp up from the state. So our state legislature actually allocates the funding in the budget that is used with the contract for our local county aging and disability resource centers. They are the center that house this position in their county. So another expansion 2018, another expansion 2019. As you can see, this was sort of, slowly progressing steps at a time. It wasn't all at once. But the statewide expansion increased the program by more than half. So we currently have about 80 dementia care specialists, 11 of them full-time FTE in the tribes. And there are about 20 or so that are half-time dementia care specialists in small rural counties. All right. There are also specific positions in a couple of our counties. In Milwaukee County, there is a dementia care specialist that speaks Spanish and is from the Hispanic community. So she serves Spanish-speaking people as a dementia care specialist. There is also an individual who is African-American and works specifically with supporting African-American people who are on this journey. And it's important because dementia is such a personal issue for not just that person who's going through it, but also their families, their caregivers, and being able to open up and share these difficult things with somebody, having them be part of your experience and your culture is very important. We've learned that from the tribes. We have an ADRC that has a couple of staff that speak Hmong, and so we've been working on a project with them as well. And everybody needs their information to be presented to them in a way that is accessible and understandable to them in their situation. So having a variety of individuals in these positions is important. So the program itself, we talk about 3 pillars of service, but really they all work together as sort of more of a web. And as you can see in this image, that dot in the middle, that can represent that person living with dementia. That could be the family caregiver. And as you move out from the center, you're adding the larger family and friends component. You're adding your community component. And as you'll see as I walk through the different things that the DCS do, it really is something that wherever they go, they are educating all systems, all people, all the time. So the first pillar is about having the agency where the dementia care specialist is housed to be a dementia capable agency. So they are responsible for training the staff, the customer facing staff at the ADRC. Our ADRCs, Aging and Disability Resource Centers, house the Older Americans Act program, as well as being the front door to our long-term care Medicaid program, and additional supports for people who are living with a disability or are older. So it's really a great funnel because people are already reaching out to the ADRC because they need something. They need to sign up for Meals on Wheels, or they need someone to come out and do yard work. They have something that they need. And so the staff are trained to recognize and ask those questions to get at what's behind the need. That if somebody is on a journey with dementia, having someone come in and do yard work is great, but that's not where it ends. So helping staff to identify when an individual might be appropriate to have a memory screen done. So we also train the customer-facing staff on how to perform very simple mini-cog and animal naming screens, which really are used as a conversation tool more than anything else. Yes, ideally, the screens would recognize that a person is having an issue, and then what we do is refer them to their primary care doctor, along with information that they can take with them. Or we offer to send it directly to their physician as well, if they agree. So it's a real opportunity to try to encourage. We just saw that person at the beginning of the timeline that recognizes they're having some kind of an issue. And then the next step was the doctor's appointment. There can be years between those two steps in that system. So helping to facilitate and encourage people to have a conversation with their physician, and that to reduce some of that stigma and fear. Explain that there are a number of things that can look like dementia that are treatable, and that it's not just doom and gloom, that there is a possibility that there could be something going on that could be cleared up. So please talk to your doctor. But then there's also the collateral conversation that happens around resources, family caregiver supports. There's a lot of education that happens around those screens. They really are a conversation tool. They also help because it's the screens that are saying you should talk to your doctor. It's not me, your spouse. It's not me, your child. It's the screens. Get mad at them. So the lessons learned from this pillar will be coming out in an article that should be published in the next couple of months. And I am blanking on what journal it's going to be in. But we partnered in the previous BOLD grant with the Wisconsin Alzheimer's Institute to do an evaluation of our screening program. It's very exciting results. The people that we were able to do follow-up surveys with, behavioral change was one of the largest outcomes from the conversation around this issue. And one of the biggest ones was exercise and diet. People made those changes simply from having this conversation with the dementia care specialist or someone from the front line who does these screens as well. They're trained on basic information. And if there is a situation that's more complex, that's when they would refer it to the dementia care specialist, who would then become involved in supporting that family. So dementia-friendly communities. This is sort of the fun pillar. The dementia care specialists develop coalitions in their counties. They are most often just one person, and there's so much to do. So they not only reach out with services through the ADRC frontline staff, but they also develop community coalitions around dementia. And these community coalitions do a lot of that work of training businesses on how to be dementia friendly. You know, it's basic customer service training, but it can make all the difference, you know, for that couple who loves to go for their Friday fish fry, and suddenly one of them is having difficulty and gets embarrassed. And if the staff don't know how to respond, they may stop going. So it helps the business retain customers. It helps customers to be able to continue to patronize their favorite places. There's special trainings that are also done for places like pharmacies or banks that are longer in nature and more on helping the professional to recognize when there may be something going on. A lot of people have a bank that they've been banking with for years and years, and that teller, who they know, may recognize that this is not the normal pattern. Who is this person coming in with her and having her take out all this money? And if I think something is wrong, what do I do? I mean, they don't have any idea how to help. And so helping to train those individuals, you can call Adult Protective Services. So there's a lot of training. Libraries. Love the libraries. They are the best friends of dementia-friendly community work. They offer space, they promote programming, and they're stigma-free. You know, our county ADRCs are county offices, you know, and people may not want necessarily to be seen going into the county office because then people are like, saw Alice going into the county building. I wonder why. I wonder what's going on. But no one ever says that if you're going to the library, right? And the libraries will host memory screening events. So people will come to the library for a memory screen and nobody's talking about them. So libraries are fabulous. And another part of this pillar are memory cafes. Memory cafes are also so critical for helping individuals to not become isolated. Oftentimes, you know, those family friends that they've had forever start to not be inviting them and don't know how to really have dinner with them because that person is having some struggles and they're uncomfortable. So they stop coming around and people lose their friends. So memory cafes, they are not a support group. They are not a training or education. They are simply a safe place, no judgment, for people to come and be social. So it's the person with dementia and their family caregiver come together. And they can bring more than just one person from their family or friends. But it's really set up to be an opportunity to do fun social things as a group. And one of the most wonderful outcomes from this, oh boy, was the Purple Canoe Club. So it was a group of people who had younger onset, met each other at this memory cafe, and became friends and started doing things outside of the cafe. And they called themselves the Purple Canoe Club because they were all in the same boat together. I know. And I'm going as fast as I can. So individuals and families is where the dementia care specialists spend most of their time, working one-on-one with family caregivers, whether it be a part of an evidence-based program, because we require them to offer at least 2 evidence-based programs. One of them has to be for the caregiver, or simply providing education and support through family meetings. If you can get the family on the same page, that's a huge accomplishment all by itself, because, infighting between the kids, nothing happens. So, and again, education, education, education. People just don't know this stuff, and there are things people can do. Oh, and the lesson learned from this one is that having that dementia care specialist be the same person that they contact whenever they call, who knows their story, knows what's been going on, and they don't have to tell everything all over again and now to another stranger. So having that consistent individual to come back to over time as things progress is important. I don't have time for this, but needless to say, they do great things. And that's my name and contact.
Thank you, Kristen. I want you to stand by. So after Stacy does her presentation, we'll have time for questions for both of you. So Stacy Hanna, who we're going to pull up shortly there, she has over 30 years in education, and she's worked in various capacities, now doing dementia education, care partner support, and end-of-life coaching. She's in my state, Georgia, the greatest state, right? Several of us here, the great state of Georgia. Right now, she is the dementia team lead for the state and has created a program for dementia care specialists, a dissemination of this. And there are 12 people one person in each of the AAAs. She also works with our dementia, Alzheimer's and related group across the state and our Georgia Memory Net. I'm going to turn it over to Stacy now. Stacy Hanna. You're going to have to unmute, Stacy.
Yes, I know. You missed the whole presentation? Did you love it? Are you informed? Dr. Mims, thank you for inviting me. And Kristen, it's crazy to me to be in the same room with you. I took my training of how to run a dementia care program from Kristen, and I can remember I was hired in November 2 years ago, and I met Kristen in February, and I was just like, oh my gosh, you're the lady who started all of this. And so we based our program in Georgia on what they started in Wisconsin, and Kristen has been a great mentor through my last 2 years. So thank you. I am part of a dementia team. It was established 2 years ago in the state of Georgia. And like Dr. Mem said, I am the team lead for the 13 dementia care specialists in each of the 12 AAAs, which I'll get to in a minute. And then I have a partner named Dina McDonald, who is in charge of the Georgia Alzheimer's and related disease plan. And then Courtney Thompson is in charge of our Georgia Memory Net Connection. It's a relationship we have with Emory, where the state funds Georgia assessment clinics throughout the state, in which Emory oversees. So thank you. If you'll go right ahead. Our vision is living longer, living safely, living well. Dementia care specialists definitely empower families and individuals living with dementia to live well and to live a long life. I always say dementia is a chronic disease, and we function with many chronic diseases. So I'm trying to get them to think along those lines. Okay, go right ahead. Thank you. Here's our team. Go ahead. Advance the slide. All right, so here we go. In Georgia, we have 159 counties. They are divided into 12 regions. Our biggest region, well, our most densely populated region right here is number 3. That is Atlanta and metro counties. They actually have 1.5 dementia care specialists, one who does all the outreach for the area, and one who does AAA education and community service inside the AAA. You can see the territories vary. Much of Georgia is a rural state, so someone may have 17 counties, but there may not be a lot of people within those counties. Please go ahead forward. This is our primary functions. We took them based on Wisconsin. We are creating dementia-capable networks through education, training, awareness, and collaboration. Just before I got on today, one of my dementia care specialists texted me that she had her first memory cafe in Athens, Georgia, and there was this space in the mall that was not being used, and they donated their space for this. And so I'm excited to see how it turned out. Next, we are creating dementia-capable communities and outreach through partnerships. Like Kristen said earlier, we do a lot of work with libraries. We are making inroads to first responders, police departments. We are making inroads into education. We have had some dementia care specialists go into high schools. They've been invited, and they do a presentation on how to support someone living with dementia. We've also had a couple of dementia care specialists present at local colleges. And down the road, that is one of my goals, is to get dementia education in a traditional education setting, because people don't know what it is, and yet we're all surrounded with it. Supporting people living with dementia and their families. Education, education, education. People don't know what they don't know. And by educating the care partner and helping them build a toolbox which they can use, can be helpful in some cases. We also explain that every tool doesn't work for everybody. One person with dementia is one person with dementia. Here's the team of us. This was taken in June. We were at a conference, and you see how silly we are. That's just how silly we are. But it is a wonderful group of women. Unfortunately, we haven't had a man yet, who have really bonded together for their passion of wanting to educate people in their communities about dementia and making it a more dementia capable environment. Go ahead, please. We are currently working on establishing dementia coalitions within their area, within their AAA region. I have suggested that it be a diverse group of people, especially someone living with the disease, a family care partner. We're looking for private businesses, hospices, restaurants, banks, pharmacies, grocery stores. these businesses come in contact with people that have dementia every day. In fact, one of the assignments I gave the dementia care specialist not too long ago was, when you go somewhere, look and see if it is dementia friendly. Like, we have a grocery store in Atlanta called Publix. And when you go into Publix, the doors just open automatically. You don't even have to think about it. When you ask, where is something, someone on the floor takes you to that space. That's dementia capable, or the beginnings of dementia capable. You know, I have goals to have larger print menus with less words and more pictures on it, or to have certain times that are sensory hours. Like, I don't know if you're familiar, but Walmart has special hours that are sensory hours from 8 to 10 in the morning. The dementia care specialists hold different education classes and seminars. They were given an opportunity of 8 different national programs to choose from, and they had to pick 2 in which to educate themselves in order to educate the community around them. And because each of us were coming from different backgrounds, I wanted everybody to have at least be able to talk a similar language, if not all. So we do a lot of Rosalind Carter Institute classes. We've done some Teepa Snow classes, Alzheimer's education outreach classes. We do a lot of virtual dementia tour from Second Wind Dreams, and that has been extremely successful with people throughout the community, with professional and family care partners, with first responders, with police officers, a variety of individuals there, especially in hospitals and nursing homes. Their minds have been opened. And we are meeting with stakeholders in the aging community. Like Kristen said before, there is one dementia care specialist in our huge territories. So we are training community leaders to be able to do dementia friendly education sessions, to be able to do a virtual dementia tour, to be able to do some other on the ground, boots on the ground work, so we can help support everyone in the community. Go ahead. All right. This is go ahead.
You keep going, Stacey.
Okay. All right. Just real quick, this is my last slide. So over the last year and a half, you can see right here in this slide where we all have on funny glasses. That's because I was doing a training on vision changes, and I wanted the dementia care specialist to see what it looks like with vision change. And I want you to know that night, some of us went axe throwing, and I put on my googly glasses to see if I could throw an axe with Google glasses, and I could. It was so like, wow. But it opens people's minds. Here, I was in a Middle Georgia AAA, and they had sensory dolls that they were giving out to their senior centers. And then over here, we were doing another type of training. So dementia care specialists could see spatial awareness and be able to do with that. So our program is, it is diverse, it is meaningful, and we're trying to reach as many people as we can. And I'm always telling my dementia care specialists who a year and a half, 2 years ago, were like, I can't do this. I can't do this. And now they are just rocking. They are doing so many wonderful things. It's so great. And for the new dementia care specialists, as we have transition in the positions. On the last slide. So in the Savannah area, they have an assisted technology lab, which is huge. And so I went on a tour one day, and this was the dementia care specialist at the time. And we were talking about underwear that you could wear that is not an adult brief or comfort underwear, as I like to call it. It's more of a reality of what underwear would look like if you had an incontinence issue, because definitely you can wear the bag underneath your pants. Mari was just explaining this. They have some wonderful tools down there to help make life easier for their individuals in the community. Thank you. And then if you needed to get in touch with me, that is Stacy Hanna at dhs.ga.gov.
Thank you
Thank you.
so much, Stacy and Kirsten. And I can also, being from the great state of Georgia, I can attest to the great work you and your entire team, Courtney and Dina as well, are doing in the state of Georgia. Kirsten, I don't know if Kirsten, oh, perfect. So you touched on something there, well, a lot of things that for me caught my attention. Specifically, you spoke about the virtual dementia tour, which we use a lot in long-term care. And I would say just firsthand, as far as staff training in particular, just the level of empathy that it brings. We start all our dementia care training with it because it shocks people and then opens the mind and the heart up to listen. So I think that's great. But you also touched on some of the work, and I know you started too, Kristen, in a long-term care setting in assisted livings. So tell me about the work specifically that you guys, or if you do much in nursing homes, in assisted livings. It is a quote-unquote captive audience, no pun intended. And I think we have huge opportunities there. We assume that individuals and staff know, all right, a lot of what proper dementia care is. And I just think it's an area that we know the individuals are there, but it's lacking. So tell me a little bit about that.
Yes, it's probably every state struggles with having quality care happen in our facilities. And I did work in assisted living for 8 years, 5 of them managing a facility. That's why we don't go into assisted living facilities or nursing homes. We don't provide training to individuals whose one of their primary lines of business is helping people with dementia, or clinicians. And we also don't work with people who are in our long-term, publicly funded long-term care programs. The reasons for that is the dementia care specialist program is free, and they would do nothing but go and train assisted living staff if that was one of their things. And assisted living facilities have the tools to provide the training, and they should be the ones doing it, not getting someone from the county for free. And you know, the people who are in the long-term care programs are also being supported by a care team. And the dementia care specialists really are intended to focus on everyone else. You know, if you're already in the long-term care program, if you're already in facility care, then you have support. But everybody, until they get to that point, has very little, if anything. And so really the focus is on that community aspect of things.
Stacy?
You're asking, we have gone into some assisted livings to educate, to do the virtual dementia tour for staff. We haven't had as much success in nursing homes, but we're working on it. So we do virtual dementia tours in that area. We do not do dementia education and training like Kristen was talking about.
One more question for both of you with such wonderful programs. Do you all have strong virtual tools or social media tools to assist with some of the community outreach and training as well?
In Wisconsin, each county has their own that they do as a part of their agency. So the state does not have actually a marketing budget. And I've been working with our secretary's office to get social media messaging out, but there's a lot of competing priorities. So
You want to tackle
And-
that Tuesday?
Yeah, I will just say, agree with Kristen. Information comes out from the local AAA about the dementia care specialist, and the dementia care specialists go door to door delivering information because each AAA has their own marketing budget and they go knocking on doors.
I would say that's one area we can certainly look at, for improvement. Knocking on doors, great, but I think the potential to really reach individuals in 2024 is really on our hands through those tools that we could possibly use.
yeah, our dementia care specialists have Facebook pages and online presence.
Good. I see Helen has her hand raised.
Thanks, Deke. Thanks to both of you for sharing what you're doing in your respective states. I think we can all learn from it, especially some of the other smaller states too. But I have a question too, because a lot of this is relying on your AAAs and state departments of aging. I also represent, the young onset community. So is there any outreach? Is this translatable? Are there thoughts looking forward to expand these programs to include people with younger onset and their families?
Our program absolutely does that now.
Does it?
It's really a lifespan program. It doesn't matter how old you are. It's funded by our legislature, the contract from the department to the county. And everyone who has any concerns about cognitive issues can come and talk to a DCS or on the phone. And going out to homes is really critical, especially if you're going to get a good idea of what's really going on for that person. So they do a lot of home visiting too.
Great, thank you. Stacy, what about Georgia?
Georgia, I would say our dementia program is for all ages and ranges of dementia. It's not just one. And we are in this 2025 year. One of our focuses is going to be on brain health, and brain health incorporates everybody. It's a huge push of ours. So anyone who needs a dementia care specialist in any of the AAAs can certainly call.
Okay, but then the onus is on the individual. I would hope that referral systems might be in place to be able to expand accessibility, so that's just a comment. All right, thanks.
Hi, Julie Crowder with Indian Health Service. Thank you guys so much for your presentations. So we now have 14 grantees, and I think what we're seeing, all of them are clinical, but many of our grantees are housed in community or public health, but definitely have a bit more of a clinical slant, I think. But I think what we're seeing forming is maybe a similar concept of this dementia care specialist like you guys have, but situated sort of between clinical and community. We've just finished our first round of 2-year grantees, and our biggest struggles were 2 of 4 grantees took 8 to 9 months to hire somebody. And then of those 4 grantees, 1 has lost someone and now needs to replace them. And it takes them a year to build competency to really be able to confidently handle these folks because they're not coming with a built-in set of knowledge. And so I'm curious, I think particularly Kristen, given the longevity of your program, how are you dealing with recruiting and then training up your folks? And it feels like this never-ending churning little wheel, and folks where we've dropped competency. So you have to have experience and a love for your community. In some places is what it came down to, but they're still struggling with kind of recruitment and then the turnover.
It's definitely a challenge, especially with our tribal nations in hiring. What we do, because again, we don't hire or supervise the DCS, but we do manage the program. We provide twice monthly opportunities for all the DCS to come together virtually. The first one of the month, we'll have a speaker usually to provide some education And the second one is sort of in office hours at this point. And we've just started doing it office hours style where people can just drop in if they want to and ask questions. And we spent the whole hour last time. So it's also helpful to give people room to be able to ask those questions versus just speaker all the time. We also connect our new DCS with a mentor. So a DCS that has experience will be there to be able to answer those on the ground questions. They certainly can come to us, the program manager, Andrea Gar, or myself. But, you know, we aren't on the ground. Andrea has some caregiving experience, and so she's a lot closer to being able, I think, to talk about on the ground experience. Mine all comes from assisted living, so it's different. And so that I really want to encourage within the DCS program that mentoring, and they also have regional meetings that they set up and run with whatever topics they want to talk about. We also partner with our Wisconsin Alzheimer's Institute and Wisconsin Alzheimer's Disease Research Center. And once a year, they put on research days for us, which is really critical because one of the big roles DCS have is to be able to dispel myths or give people the real skinny on these new treatments, you know, because people will hear about it, but it's a very small target audience that's actually eligible. And our systems aren't even set up yet. There's one clinic or two, I think, that are actually doing it at this point. So, you know, providing that knowledge background for the dementia care specialists and their support and feeling as a part of a group is really how we try to avoid turnover whenever possible. But they are locally supervised and hired, and we don't have any control over that.
So dementia care specialist, it's a gold mine of a role. It's not all over the country. I hear you saying 3 roles: educating the people in the ADRC so that they can man most of the lines, educating the community so people can live in the community longer, but then also trying to do some individual cases. You have 80 in Wisconsin. Stacy has 12 in Georgia. Being able to grow this role is an interesting thing that I think we all in each state has to accomplish. But I want to come back to you, Kristen. It almost sounds like 3 different roles to me. Can you comment about why this is all in one?
Well, because when I created it, it was my one shot. So I wanted to include everything that I could think of that would be helpful in the community. And it is a lot, you're right. Being able to do that one-on-one work with families is very different from presenting at a conference and public speaking stuff. And they're expected to do both. So it was one of the things that I worried about. I was like, are we going to be able to find enough people to fill all these jobs who can do this type of work? And happily, the answer is yes. People have a lot of passion for this topic, and they're the ones who gravitate towards these positions. You know, for our job description, college level education and 1 year of experience working with people with dementia or family caregivers who are not your family. So they have to come with some experience already of what it looks like. How do I support someone? So that sort of hands-on thing you can't teach in a classroom. So they have to have some of that coming in. In the tribes, it is different. We do not require the college education, and we absolutely want the right person in the job within the tribe, and we can train them on the basic things that they need to know. The tribes really struggle with turnover more than the counties do. I've learned so much from the tribes.
I just wanted to ask a quick question about what you just said in terms of, did I hear you correctly that they don't have caregiving experience if they have cared for a family member? And if That was what I heard. Can you say why that would exclude them from the role?
Because there needs to be some breadth of experience. If you work with one person with dementia, your family member, first of all, because of your family, it's going to be a very different experience for you than it is taking care of someone you don't know. And secondly, you need more than one person's experience in order to have an understanding, I think, because everyone is unique.
Thank you for clarifying.
Well, thank you. I appreciate you coming today, and thank you, Stacy, for being on the line. I thought that this was important to be part of this clinical day so that people realize after the diagnosis, you live in the community, and we need to look at all aspects of resources that's going to be available there. We're going to turn to another section now. It's Bridging Healthcare and Social Services for Persons Living with Dementia and Their Caregivers. And for this presentation, we are very happy to have Erin Long, who is a member of our Napa Council. She's a social worker by training, and she leads the Administration for Community Living's Alzheimer's Disease Program Initiative. She has spent the past 2 decades working to achieve equity for older adults. She works with grantees across the country to help shape these new programs. And she told us about Kristen when we were looking for this. She also supports dementia caregivers by providing training to help support them and their loved ones in any way possible. She and her team have positively impacted the reduction in stigma toward individuals living with dementia. So let me turn you to Erin Long.
Hi, everyone. Thank you so much for the opportunity to talk to you about our recent efforts. ACL partnered with ASPE, Helen Lamont and Maria Teresa at ASPE to develop an issue brief on bridging healthcare and social services for people living with dementia and their caregivers. And today I'm just going to give you a little background on the rationale why we decided that this was a really important topic, and it's kind of rounding up the conversation of today. What drove us to these decisions, and then what we found out, sort of the highlights of the paper so that you guys can all go read it when we're able to post it online. Next slide, please. So I just want to give you a little background to level set on why we decided to undertake this effort. For those of you unfamiliar with the Administration for Community Living, it was actually created in 2012 by bringing together the federal entities working with older adults and people with disabilities. And they were brought together to advance the principle that people living with disabilities and older adults should be able to live where they choose and with the people they choose and participate fully in their communities. The AOA is at the core, the Administration for Aging is at the core of these entities. And that's really what I'm going to focus on here. And we're governed what's known as the Older Americans Act. The Older Americans Act was actually enacted in 1965, right along with Medicare and Medicaid. I'm just going to give you a quote from the Older Americans Act just so you can get a sense of who it is that we're serving. So the Older Americans Act assures that preference will be given to providing services to older adults with the greatest economic need and older individuals with the greatest social need, with particular attention to low-income older individuals, including low-income minority older individuals with limited English proficiency, and those residing in rural areas. Next slide, please. So just to get a sense of the breadth of the aging network is what we call it, that the Older Americans Act provides resources to support. It's 56 units on aging, 282 tribal organizations, 618 area agencies on aging. You get where I'm like building here, that these numbers are just rising and rising. More than 20,000 service providers and hundreds of thousands of volunteers. And all these entities together provide services and supports to nearly 1 in 5 seniors. Essentially, I'm not going to go through all of these things, but that's 300. Through these AOA programs and Older Americans Act funded, whether formula, what we call formula mandatory grants or discretionary grants, we're serving 358 million meals, delivering 24 million rides, 42 million hours of personal care, going on and on, homemaker services, caregivers, 750,000 caregivers assisting, 6.3 million hours of respite. I mean, we can go on and on, but basically we're serving 11 million seniors to remain in their home at low cost through the provision of low-cost community-based services. It is said that, and there's documentation to demonstrate that there's a $3 to $1 return on federal investments. So the government puts in $1 and $3 worth of services are delivered out in communities, and that really comes from the engagement and a lot from volunteers. But so who do we serve? People 60 and older are eligible to access older American service and supports. Poor and near poor, people at 150% at the poverty level. People living alone, frail and vulnerable people, people with diabetes, heart conditions. And this is just the basic population we're serving. People at risk of ER visits, hospitalization. Over 92% of older Americans at clients have multiple chronic conditions. 69% of the case management clients take 5 or more medications a day. So there's just a tremendous amount of work going on through the implementation of the Older Americans Act. So based in a nutshell, mandatory and formula grants from the Administration on Community Living, Administration on Aging provide home and community-based services, concrete home delivered meals, nutrition services, incentive programs. We call it NISIP, the National Family Caregiver Support Program, Title VI, Native American Nutrition and Caregiver Supports, Long-Term Care Ombudsman, Elder Abuse and Neglect and Exploitation Programs. Just a very, very broad range of services and supports going to people. Next slide, please. So sort of reinforcing what I said in the last slide, again, 6.2 million hours of respite care provided, supporting caregivers. That's through our National Family Caregiver Support Program, NFCSP, you might have heard referred to, and our Lifespan Respite Program. We heard someone talking when she was talking about the care planning about the web organizations having websites so people can see the menu of services that are available. Through the Older Americans Act, we provide information and assistance, and there's 1.15 million contacts through people accessing assistance service supporting caregivers. We've answered 12.6 million information and assistance calls through our Elder Locator, which is a free service that people can find services through by zip code, actually. 9.9 million hours of adult daycare. ACL also funds the business acumen initiative that is really important, especially as we're going into GUIDE and the building relationships between healthcare systems and community-based organizations providing dementia services or other services, is building business acumen to support strategic business partnerships between the healthcare sector and the HCBS sector. ACL programs also provide evidence-based interventions, not only in Alzheimer's disease, but chronic disease self-management and falls prevention. And then 3.6 million hours of case management. Next slide, please. So I'm the Alzheimer's lady, so I couldn't do this presentation without giving you a snapshot. If anybody's been to recent presentations, they may have seen this slide before. This is a representation of what we do at ACL for our Alzheimer's disease initiative programs. Presently, we have 4 core programs. We do our state, community, and tribal grant program. And then we have a new program that we funded, the Alzheimer's Association, that is supporting state and community innovations in dementia-specific respite programs and services. The National Alzheimer's and Dementia Resource Center, which has a library of tremendous resources. And then we fund a reasonable portion of the Alzheimer's Association's National Alzheimer's Call Center. And then in grants.gov, you would find a forecast for a new program that we're going to have in 2025 that's going to be developing dementia-capable community health worker programs in the aging network. It was super exciting for me to see the 3 entities today's who either are presently active grantees or have previously benefited from our ACL ADPI state, community, and tribal programs. So several iterations from the early days, we've been working with Wisconsin and Kristen and doing great work there and helping them build and expand their DCS program. Dr. Hamilton's program, we helped them expand it with Hospice of the Valley. And more recently, we're in very early stages working with the state of Georgia on expanding their statewide dementia care programs. So all of the things discussed on these 3 earlier slides are done under the authority of the Older Americans Act with our annual funding. I just thought it would be important for you to know the funding level that all of this work is accomplished with. In 2024, our budget was $2.372 billion. Interestingly enough, that's a $6 million decrease from the 2023 level, but I think that there's a variety of things in play there that informed that decision. But remember, there's the 3-to-1 federal investment. So think what that what we're able to do with that the value of what we're able to do with that $2.372 billion to serve the older adults and in our communities across the nation. So with that, I just want to take you to this new issue brief that we worked with a contractor, and ASPE and ACL worked together to complete. It was completed in September 2024, so it's brand spanking new. And it's entitled Bridging Healthcare and Social Services for People Living with Dementia and Their Caregivers. Next slide, please. So for the paper, we set out to do 2 things. First was to identify core components of successful dementia care programs that bridge the 2 systems and highlight examples from the field. And basically, we asked the stakeholders, and we did it with 12 stakeholder organizations. So we asked them, what are the components of community-based dementia care management, training, and education for people living with dementia and their caregivers that effectively partner with healthcare providers? We were really trying to hone in and find who's doing what and what's working well. And the second question was how are effective programs structured? The second question that we asked was, what are best practices for aligning those community-based service and healthcare systems to deliver comprehensive dementia care? What are the best practices for aligning these systems to facilitate coordination of care that maximizes the utility of both systems? They both have strong suits. And what are the barriers to alignment? And are there workforce enhancement solutions to addressing any disconnects that exist? Second, we wanted to better understand the barriers and promising practices for bridging the CBOs, the community-based organizations and healthcare systems, in the provision of comprehensive dementia care. We asked, what are the barriers for expanding the availability of these services and maximizing the benefits of dementia-specific service alignment, what are the options for making these models and collaboration scalable and sustainable? And secondly, what are the alignments of the health system and the social service systems being articulated to facilitate the alignment of the care in a coordinated manner? So we took all these, we worked really hard to get these questions together, and we took them, we did an environmental scan, and then we went to 12 stakeholders across 4 categories. Those categories were the community-based organizations, the healthcare systems, federal and state government agencies, and policy experts. Next slide, please.
Karen, as your partner on this, can I just jump in real fast? This is Helen. I just want to add a little bit of context. You can comment on it as well. We recognize that there's now an opportunity to do this bridged service provision between healthcare and community-based organizations through GUIDE. But some of these organizations have already been doing it, and there's nothing that precludes this from happening in other communities currently. So we really wanted to look at where it is happening and to think about in the current context outside of the GUIDE model, what could be done to further these collaborations without just being in GUIDE. So not to wait for GUIDE to wrap up, but right now, what could we do to help these organizations work together?
Absolutely. And I would just layer on top of that, that GUIDE is helping a lot of people, but there's a whole other audience of people that aren't even going to like participate, their GUIDE is not in their communities, or they're not eligible for one reason or another. So as Helen said, it's already being done in some places, but GUIDE isn't the magic bullet for everyone. So it's important to make sure that we're continuing to think of ways to engage other communities and services. Anything else, Helen?
No, that's it. Sorry to interject.
Nope. Thank you. So both systems are engaged in providing all of the items that we laid out on this slide. It's the identification of systems, care planning, referrals, ongoing assessments of needs, caregiver supports, and med management. Sort of as an example of the depth of these areas of concern, I just want to dive in. I'm just going to do a little bit of a deep dive into the identification of systems, just so that you can sort of see. You could chunk each one of these areas down. We certainly don't have the time to do that, but when looking at identifications of symptoms, both CBOs and healthcare systems can and do identify dementia signs and symptoms. Primary cares often first to receive concerns regarding cognitive health, and this can be expanded if they incorporate cognitive screenings into annual wellness visits. CBOs, on the other hand, may identify cognitive changes in their clients, and they make referrals for further evaluation when they can, and they make further evaluations, and they can and are expanding this by including questions about memory concerns as part of service intake. So everybody, when people get sign up to participate in supports and services at the community level, everybody does an intake, and then they have, whether they have an official electronic health record system or they have their own internal monitoring system, they do an intake and they can make that part of their intake. And the CBOs are also training staff and volunteers who have frequent contact with older adults on signs of cognitive decline and screenings and structured referral procedures. A perfect example of that would be Meals on Wheels providers. Who knows people better than the people that are delivering them food on a daily or weekly basis, depending, the pandemic changed things a little bit, the way Meals on Wheels goes these days. But those people that see them on a daily basis know they're people, and when they can see the change, then some CBOs have done dementia education and referral education to teach Meals on Wheels volunteers to make those referrals and be sort of gatekeepers in their communities. Next slide, please. So back towards sort of tying the Older Americans Act to this work that we're doing is that there's challenges. The rapidly increasing demographics, increasing complexity of the needs of individuals and their families, and Another one that's less sort of obvious is the healthcare sector referrals that are coming into the community, and it's not resulting, they're not, the cost of the care isn't being shared. Next slide, please. So the issue brief examines the barriers to coordinating care, and these 4 themes rose to the top. While all of these themes are very important, I'm going to dig a little deeper in some more than others, but it's, workforce challenges, different funding sources and payment structures, having the organizational buy-in, and communication and data sharing between the 2 systems. Next slide, please. I don't think anybody would be surprised that a key finding is the limited availability of a trained dementia care workforce. Organizations struggle with sufficient staff trained, limiting the ability to provide or expand services. It goes to, a couple people have brought up today the turnover, the revolving door in staff, and constantly being being responsible to train staff, inadequate funding and compensation, the lack of dementia training for health and social services staff, training for requirements for professionals outside of the medical field are lacking and inconsistent, and there's limited opportunities for specialized education and clinical placements in dementia care. Next slide, please. So one of the CBOs, so they did all these interviews, and one of the CBO interviews put it just about as succinctly as I can think of, and it said, if the person's living with dementia or their caregivers can't pay privately and they're not Medicaid eligible, we have too much demand for the funds we've got. So there's not enough money to pay for all the services people need. So to address, so the challenges, those separate funding sources, healthcare coverage through Medicare and sorry, my slide language is wrong. Medicare and Medicare Advantage, I'm sorry. Community-based organizations aren't typically eligible to bill Medicare or enrolled billers. That's changing a little bit. They're starting to begin to do that. Updates to Medicare don't address the community-based organization challenges. Social supports aren't covered by traditional payment sources. Limited reimbursement for services, training for caregivers and training in education, and limited funding through the Older Americans Act to support long-term services and supports is limited. And as such, when the caregiver and dementia population are being referred in, they already have pre-existing wait lists because they're essentially underfunded. Then infusing more populations lead to already pre-existing wait lists and unmet needs. Next slide, please. So this effort was able to we're able to identify some promising practices and recommendations to address funding challenges. The efforts to increase understanding that investment in meeting the social related needs of people living with dementia and caregivers leads to long-term cost savings. It gets into what I've heard several times today about those multiple visits to the ER, hospital stays, earlier placement, obviously keeping people in their homes and community longer is usually what people want, but also better for the system. Organizations have created community care hubs to lower risks for CBOs and healthcare providers to build partnerships and facilitate collaboration, sort of safety in numbers. Encouraging Medicare and Medicaid to cover a wider menu of social services for people living with dementia and caregivers, complement but not replace Older Americans Act funding, and adopting flexible payment design or alternative payment models capable of covering recommended services for dementia care within and outside healthcare system. One example would be a fee-for-service based through vouchers provided to the people living with dementia, and then they can go to the CBOs for the people with dementia and their caregivers to go to CBOs and for specific services as they're referred out by the health system. Next slide, please. So challenges with organizational buy-in are recognized as ongoing for a broad range of reasons, including but not limited to high initial costs and time commitment, getting all the staff trained up. Even it's surprising, you think, even just getting staff, internal healthcare system trained up on the resources available in the community is often a challenge. And then getting them to refer people to them, acknowledge that they're important and refer people to them can be a challenge. Requiring, to do that, to do the change, it requires staff training and changes to organizational structure. And, everybody's busy and it's hard, competing priorities. We've also heard that today, there's a lot of important work that needs to take place, and it's about getting a champion in an organization to recognize that these two systems working well together, it will benefit them and their community that they serve. Next slide, please. So it's imperative that CBOs and healthcare systems understand the need and have the will to align their priorities. They need to identify, in order to do that, you have to identify champions in both systems to bridge culture and gaps, build understanding of common goals, shared responsibility and collective vision, expand understanding and use of multidisciplinary approaches and to deliver dementia care, align social services and healthcare, to have demonstrated promising outcomes, and programs. Sorry about that. Programs should make use of the quality measures to monitor performance and evaluate clients' status and needs, and identify and use technology-based solutions. So another quote that we had from a stakeholder was, community-based organizations need to understand the mindset, culture, and the language of the hospital. And the hospital people have to understand the language and culture of the not-for-profit that the CBO is still working within. So essentially, systems need to speak the same language, and speaking the same language will go a really long way towards addressing communication and data sharing challenges. Next slide, please. So these challenges are not going to surprise anybody. There needs to be more communication. CBOs have less, but the reality is that CBOs have less digital infrastructure and they may not have the capacity for data sharing. They often encounter barriers when trying to access electronic health records and may not be able, even if they can access them, they may not be able to add to them. So then it's a one-way conversation. And they're not, CBOs also aren't required to collect data in the same way. And so they don't necessarily have evidence of the outcomes of their work, which obviously is extremely important when working with the healthcare system. I think that community-based organizations are getting better about collecting data and being able to speak the language or not speaking the language, but getting the information that the health systems need. Collection of quality metrics is ubiquitous amongst hospitals and health care system settings. CBOs may need a little bit extra support on that front, and traditional quality and outcomes measures used by healthcare systems are not necessary or reflective of the values in coordinating care and priorities of people living with dementia and their caregivers. So next slide, please. So there are a couple of promising practices for communication and data sharing. Just talking, just holding those regular meetings for the care team, those multidisciplinary teams that we're all talking about these days. Having these meetings to discuss the needs of the people living with dementia and their caregivers, and reviewing goals and care plans, creating clear role definitions and protocols for communication and data sharing and work processes, having it all laid out before you even like serve person one under a new program, and establish shared data systems that facilitate automatic closed loop referrals. Cannot say it loud enough. Closed loop referrals that, I know I heard someone say it today, diagnose and adios. I mean, that's the horrible thing, but we want to, before that, you get those referrals and making sure that they're warm handoffs and that everybody has the information that they need to, no matter who's making the referrals. Many communities are going to gatekeeper systems, but getting that information exchange between the CBOs and the healthcare systems and making it efficient and effective. So basically, I know I spewed out a whole lot of stuff in a short amount of time. It leaves us with a couple of questions, considerations as we continue to move forward to make the landscape better. Is how can dementia care service and funding needs from the perspectives of both the CBOs and the healthcare systems be addressed? And how do we ensure value of necessary home and community-based services is recognized and financially supported? And that's really that piece of funding healthcare and funding those home and community-based services that are an integral part of keeping people home in their homes and communities longer, and ultimately in keeping a higher quality of life for people. So with that, next slide, I'm done, and hopefully I didn't miss anything. If Helen wants to add anything.
Great job, Erin.
And thank you, Erin, kind of pulling it all together. So we have two silos. We got the community and we got the healthcare system, and they don't talk. They're serving the same group of people.
Yep, pretty much.
It's a long-standing problem. But this is just the United States. And it's probably artificial based on the way our government is designed to administer funds. I'm wondering, are there some places that's getting it right where you are able to transcend the silos because it's not these two different funding barriers? I know that wasn't the charge to look at, and that might not be an answer you can make, but I put this out broadly. Sometimes we have to learn from other systems that are designed to get a different result. Our system is giving us the result that we designed it to do, and we're now trying to figure out a way of making it do something different. And I don't know that GUIDE can do that, because fundamentally the challenge may be the whole design of the payment system as being a medical model as opposed to a social model. Your thoughts, and then I'll open that same question up to others in the room.
I would say that there are other people in the room, at least they were in the room at one time today, that are probably more well-versed in the international landscape than I am. There are certainly best practices that are brought forward, but from a variety of places across the world, but I'm not in a position to comment on how we could adapt ours to theirs.
Okay,
But
thank you,
maybe if
Erin.
Joanne's still there, maybe she might have some insight.
Well, there's Joanne, there's Richard, there's Sherry. There's a few people in here who might have some ideas. And Richard, you just were on a panel talking about healthcare structure changes in different international settings. And did you see any feedback from other countries that may have been different? And Joanne's been traveling the world, and maybe she saw something that'll help us out.
No, thanks for the chance to comment, but I think I don't have a lot to offer. Those conversations have generally not been to this very critical and basic question raised here.
I think you acknowledge one of the hardest parts of comparing the US with how care is delivered in the rest of the world, and that's the payment model. It incentivizes, to use the word we've been using all day, a different type of care and a different type of integration. But I do think there are principles that we use in a lot of our work that you've heard Erin talk about and several other presenters, which is person-centered care models. And those person-centered care models are a global philosophy. Some countries may invest deeper in that. And I think there's also cultural norms that we have to take into consideration along with those person-centered care models. So if we think about what is one of those normative factors for all of us, I think that's one of the biggest ones. I think the payment system makes it more complex to come to agreement on how do you meet on those person-centered care models. But I think there are things that we can learn, certainly, but I think that's one of the biggest roadblocks that we have to implementing here.
I think there may be some lessons we can start to learn from some of the tribes we're working with, who are working on these grants, both from a community-based perspective and also a clinical perspective. I will say it's challenging for that almost in every case, not in every case, but in most cases, there's work to be done to bridge, even when they're both functioning as part of a sovereign nation caring for their people, right? There's still work done to bridge between the sort of medical model and clinical sort of approach and the community-based approach. But they're starting to do some of that work. It doesn't always translate, because in many ways it's probably better to think of them the way we think of other countries, right? As sovereign nations that are caring for their people and can set up in structures. I will observe, and Sherry may have perspective on this, just to reinforce what you pointed out, Joanne, that sometimes changing the payment model on the medical side it's surprising how little it seems to affect that relationship between the clinical side and the community side. Even when we can draw out the lines, when we can draw the line and show the potential return on investment, there's a lot of choices to be made under these payment models. And that's a difficult choice when they choose to engage on the community side. And that's a challenge.
Sherry.
And I think this will just add to the complexity, but the complexity is real, and it's grounded in what the statute says, like thou shalt pay for, right? And so, if you actually look at where we're trying to blend the edges, it's in the integrative physical and mental health work, because it's really important to actually understand that there's no physical health condition that isn't impacted by your mental state, whether it's a mental health condition or it's cognitive impairment, or, so part of it is creating that understanding, and it's building on the fine work that research has created, the evidence. I think there's another part of it, though, that we have an opportunity to, and keep in mind, this is a very biased view. Remember, I'm a geriatrician, and we grew up in gerontology and geriatrics, it is team-based care. There's no other way. So, how do you actually enable team-based care, which is centered around individuals and their needs to thrive? So, one observation has been that, as we look at these new care and payment models, I think there's a real important opportunity for us to seize, which is be clear about what the needs are without the prejudice of who is going to be providing the service or the care. And let's see how we can reconstruct the care services that are provided based on what people need, as opposed to that, what people do, whether it's physicians, nurses, whatever label it is. I think it flips the conversation back onto focus on the people who need something from us, most times where they're not actually getting what they need. So.
And thanks you for identifying the constraints in the system. Joanne, were you going to say something before I go to Richard?
Kind of, but I think the biggest piece within, the thing that I keep thinking about, regardless of who is paying for it, regardless of what the payment model is, we have to have capable communities. We have to do that in a way that is culturally valuable to the place that it is at. We have to reduce stigma. And we have to do that in a way that creates inclusion in the community for those who are receiving the service. And I think that was the nice bridge with what you've done with this session, Adrian, is diagnosis doesn't happen in a vacuum. It happens in the community. And we have to be able to bring people back into the community as well.
Richard?
Well, Joanne and Cherry have made some very, very good points. I should add, there's no shortage of research that is comparative globally, internationally. No shortage of information about which outcomes in which countries with which policies are doing better or worse, what's happened in individual cases when a change in compensation models or social structures occurred. But translating that into a political or social will is a very different story. And I don't know if we want to, if it's worthwhile, this group or any other, to spend time looking at some of those international comparisons, because the data are there. They're natural experiments. They're not randomized control, but some of them are quite compelling. But translating that to what is feasible here is another challenge.
I think you said that well. We're very clear on the challenge, and we don't have the answer here because of our current structure. Whether we can get there will be interesting. So I'm going to close our part of the day that was on the clinical care committee, and we're going to transition now to the risk reduction subcommittee presentation. And I'm very excited that Joanne has pulled together an excellent panel for that. We are going to forego the break and move straight forward. Thank you.
Produced by the U.S. Department of Health and Human Services.